Hi, I'm Frank Miller from Northwestern University. I'm going to be focusing on liver lesions. Obviously, I can't discuss all the liver lesions in the short time that we have available. I have no disclosures related to this presentation. So I'm going to demonstrate the typical and less typical CT and MR features of the more common liver lesions. I'm going to specifically focus on hemangiomas, focal nodular hyperplasia, and adenomas, but discuss other lesions as well and discuss their mimickers. And I like to do a problem-based approach, including the mimickers, to give you an idea of what the lesions look like. As background information, a large number of focal hepatic lesions in adults are being seen incidentally as we image patients more and more. But it's important as radiologists to characterize these lesions accurately, and many of these are benign even in patients with no malignancy. MR has been described, and I think it's true, as the best method for characterization, and that's been shown in the ACR appropriateness criteria as well. And the vast majority of the hope is that we can characterize them by CT and MR and not require biopsy. So the first case that I'm going to show you is this case. Upper left image you can see is a T1 fat suppressed image. Here's a T2 weighted image in the axial and coronal plane. This is early after contrast material and progressively later. So the question is, what lesion is this? And I'll give you a few minutes. So your choices are A, adenoma, B, focal nodular hyperplasia, C, hemangioma, D, hepatocellular carcinoma, or E, metastasis. And the answer is hemangioma. So hemangiomas are the most common benign hepatic tumor seen in 4 to 8% in autopsy series. The vast majority of these lesions are asymptomatic, but it's critical to diagnose these and avoid unnecessary biopsy, surgery, or workup. And basically, as seen in this path specimen, it's always good to look at the pathology. It's a sac of blood. Using CT, which is what we most commonly use when we're imaging patients, you see the classic early peripheral nodular enhancement with progressive filling in, and usually it's centripetal filling in. And the thing you want to do is you want to compare it to vessels, and it should be similar to vessels, although it doesn't always have to be, but that's a good control to see that peripheral nodular enhancement. So MR can definitively characterize the vast majority. On T2 weighted images, they're classically high signal intensity. They've been described as light bulb bright, but in my experience, a lot of times they're not as bright as a light bulb. And following contrast, similar to CT scan, you're going to see that peripheral nodular discontinuous enhancement with progressive enhancement toward the center, and you want it to remain hyperintense to liver on delayed images, unlike hypervascular metastases, which may wash out. So here's an example. This is a smaller lesion, but it has the classic appearance. It's low signal and similar to vessel. On the T1, it's dark, similar to the adjacent vessels. On T2, again, it's bright. On early post-GAD images, you can actually see some peripheral nodular enhancement. And on the more delayed images, you can see that it completely fills in as illustrated here. So what are the atypical hemangiomas? In my opinion, they're actually typical, and it's typical for their size. So in other words, the small hemangiomas, the ones that we know of as the flash-filling hemangiomas, meaning that they rapidly, completely enhance on the arterial phase, these are the ones that are also going to be high signal intensity on T2 and retain their contrast similar to the adjacent blood vessels. In contrast, the giant hemangiomas and the exact size isn't really that important, but these are the ones that are more heterogeneous. They have a high signal intensity central scar with a typical peripheral globular enhancement and lack of enhancement of that quote scar in the center, as we showed on the index case. And the ones that are really challenging are the sclerosing hemangiomas. These are the ones that can be difficult to diagnose as they lack the typical high signal intensity on T2 or the peripheral nodular enhancement that we like to see. So here on CT is what I described before, the flash filling or small hemangiomas. You could see that it's dark on the unenhanced images. You could see that it has marked enhancement on the arterial phase and stays similar to vessels on more delayed phases referred to as blood pool. In contrast, the small hemangiomas on MR, the flash filling ones, as I mentioned, are going to be bright on T2. So you can see the T2 is very bright. What's interesting is on the arterial phase, you can see this marked arterial flash filling enhancement, but what you often see on CT or MR, you see what's referred to as a transient hepatic intensity difference on MR, transient hepatic attenuation difference on CT, and that's common in these small hemangiomas. And on the more delayed images, you could see that it remains similar to blood pool. What about the giant hemangiomas? Well, the giant hemangiomas, what I showed in the index case, you could see it's low signal on T1, but what's interesting about these, they're bright on T2, but they have the central quote scar, which is brighter than the remainder of the lesion. And following contrast, you could see that classic peripheral globular enhancement with progressive filling in. And you don't have to wait till they fill in, because in fact they won't fill in. So the central scar will not fill in, so you can wait for quite a while. Another example, this time with CT, you see on the unenhanced images the lesion. You see that cotton wool appearance of enhancement with peripheral globular enhancement and progressive filling in on more delayed images. Another patient, the reason I'm showing this will become evident, but you can see these peripheral nodular enhancing lesions, most consistent with hemangiomas throughout the liver. On MR, similarly, you see that peripheral nodular enhancement, again, similar to the blood pool, consistent with hemangiomas. But what was interesting here is, notice this patient has a large mass in the pelvis. It's low signal on T1, high signal on T2, and shows some filling in. And more interesting is you got this time-resolved MRA, so similar to the angiogram, you can see that cotton wool enhancement of the hemangiomas. You can actually see that pelvic mass starting to enhance. But what's interesting here is now you start to see these enhancing nodules adjacent to the sigmoid colon and rectum. So the question is, what's this condition? This is actually almost like a case report or tongue twister, blue rubber, BLEB, NEVUS syndrome. It's a rare syndrome, mostly sporadic. It has multiple cutaneous and visceral cavernous hemangiomas, but the reason it's important is because it can lead to potentially serous or fatal bleeding from the GI tract. Usually it's chronic, and these nevi, as illustrated in this case, have been reported throughout the body. Okay, this brings me to my mimickers or tricky cases, which is what I like to do. So this patient, I didn't give you the history. He's actually a 50-year-old male. You get the classic non-revealing history, left upper quadrant pain. But what do we see? We see a lesion with some peripheral enhancement. So the question here is this a hemangioma or is this hepatocellular carcinoma? And it's hard to tell. So the MR I'll give you, it's dark on T1, bright on T2, peripheral nodular, it's filling in. So you might think that it's more likely what? A hemangioma, right? Well, interestingly enough, this is the follow-up imaging. So the initial image, you see it here nicely. Now you see it's more heterogeneous, heterogeneous enhancement, and certainly growing. I might have thought this might be a cholangio because it's bright on T2, but this actually, I looked at the path report, and it was a hepatocellular carcinoma on biopsy. And you can see that it's clearly more heterogeneous, and obviously if it was a hemangioma, it wouldn't have this appearance. How about this patient? A different patient. Again, you see that peripheral nodular enhancement. Again, you see it's bright on T2. So again, now you're a little gun shy. I'm asking you, is this a hemangioma or is this a hepatocellular carcinoma? Normally ask people to raise their hand. No one raises their hand. But in this particular case, what did this turn out to be? Hemangioma. And how do I know that this is a hemangioma? Well, old films are your friend. You should always go back on the PACS and see if there's been prior imaging. And interestingly enough, in this particular patient, we have an MR from 3 years earlier. It's dark on T1, bright on T2, peripheral nodular enhancing, and progressive filling in. So if it was a HCC or a cholangio or some other lesion, you would have expected that it would probably grow over a period of 3 years. So we could confidently consider this a hemangioma. What about this patient? So again, we have a lesion. The question is a hemangioma or hepatocellular carcinoma. In this particular case, what would you do next? Well, the answer, in my opinion, is MR, although some places do triphasic CT, but a lot of times I think the MR is more revealing, and obviously patients don't want to have the same test again. But the MR in this case was helpful. You could see the lesion, although being dark on T1, bright on T2. What do we see after contrast? The nice thing about MR, it doesn't have radiation and you have multiple phases. You can see there's a peripheral nodular enhancing area, but notice on the more delayed images, it doesn't progressively fill in. Instead, now we start to see capsular enhancement, and this turned out to be hepatocellular carcinoma. How about this one? Again, same question. Is this a hemangioma or hepatocellular carcinoma? T1 here, T2 here. Central area is bright, but it's not classic for hemangioma because, again, the surrounding area isn't bright. What about after contrast? Here's the early arterial phase, more delayed phase, doesn't progressively fill in. It looks fairly nonspecific. It does have the nodular enhancement, though. What did this turn out to be? This was a sclerosing hemangioma. And these are the ones that are difficult to diagnose as they may lack that typical high signal intensity on T2 or that peripheral nodular enhancement. This is a slide that my family thinks I show in all my talks, but I like it. You're confused. You're wondering which way you should go. Actually, I had somebody in my media service make this slide. And this is my advice. It's a difficult distinction, but I think MR is helpful in the diagnosis. What you really need to do is you need to consider the patient population. If it's a cirrhotic or risk factors for HCC, certainly hemangiomas are significantly less common. It's not 5% of the general population. And the important thing is you need to consider HCC in a cirrhotic even when it mimics hemangiomas. And a quote that I like to use, which I learned from the late Rich Barron, who was at University of Chicago, is that nothing wants to live in a cirrhotic liver, the exceptions being HCC, dysplastic nodules, and regenerative nodules. So hemangiomas may not be specific nor typical in cirrhotics. It may decrease in size. It may become more fibrotic and not bright on T2. And as I illustrate, it's helpful if you have old films to show the more typical features or to show stability. And sclerosing hemangiomas are going to be a difficult diagnosis. And for these, we need to either show stability or do a biopsy depending on how suspicious you are. How about this patient? Well, on most days, you see an echogenic lesion. It's going to be a hemangioma. In this particular case, what's interesting is the patient had an MR to characterize it, and the MR in this case was helpful. So here we have a T1 in phase. We have an opposed phase here. You can tell it's opposed phase because the organs are etched in black. And in this particular case, what's interesting about it is you see there's a focal area along the medial aspect, which is losing signal on the opposed phase image. So if we see something losing signal on opposed phase image, it implies it has fat. On T2, it's a little bright, but certainly more similar to spleen. It's not CSF bright, or it's not very bright relative to that you might expect in a hemangioma. And just as important, or more importantly, you don't see that peripheral nodular enhancement. And again, the presence of fat is not typically seen in hemangiomas. So fat is your friend. Looking at lipid, you can see it's in some of the liver tumors, certainly hepatocellular carcinoma, certainly adenomas. You may see occasionally an angiomyolipoma or a lipoma, which typically has macroscopic fat, and rarely can be seen in focal nodular hyperplasia, but in my experience, the majority of the time you see it with FNH is in the setting of diffuse hepatic steatosis or fatty liver. How about this patient? So this is an example where you see a continuous ring of enhancement, and then when you look closer at her history, it turns out she has a history of breast cancer. So whenever you see a continuous rim of enhancement as opposed to that peripheral discontinuous rim, you have to consider other things. And in this particular case, given her history of breast cancer, as expected, this turned out to be ring enhancement due to breast cancer metastases to the liver. So hemangiomas, as I mentioned, tend to have discontinuous ring of enhancement with peripheral nodular enhancement, and then they show progressive centripetal filling in with persistent enhancement. In contrast, malignant lesions can show that continuous ring of enhancement. And as illustrated here, which we better often see on MR than on CT, what does this show? It shows a lesion with a continuous rim of enhancement, and it has what's referred to as the peripheral washout sign, where that peripheral area of enhancement is now washing out. And that's consistent with metastases, in this case from renal cell cancer. So peripheral washout sign, as I mentioned, is common. Often peripheral washout is on delayed films, it's specific. It's not seen in benign lesions, and it helps distinguish hemangiomas from and focal nodular hyperplasia from that of metastatic disease. And as I mentioned, it's better seen on MR than on CT. How about this patient? This was a difficult case, and it's always easy in retrospect, right? This lesion is bright on T2. It has some progressive peripheral enhancement with filling in, but notice it also has some volume loss, right? So it has some capsular retraction associated with it. So as a result, this was called either a sclerosing hemangioma or cholangiocarcinoma. It was advised to get a 3-month follow-up. And what happened on the 3-month follow-up is illustrated here. Unfortunately, this was cholangiocarcinoma, so the lesion got larger. Again, easier in retrospect. How about this? This is the more typical appearance of cholangiocarcinoma. What do we see here? We see a continuous rim of enhancement surrounding the lesion. Again, we see that capsular retraction, which is classic for cholangiocarcinoma. And you can see progressive filling in on more delayed images. So this was, as I mentioned, I gave it away, but people like multiple choice questions. This was cholangiocarcinoma. And for these cholangiocarcinomas, the 10 to 20 minute delayed imaging can be helpful because they're fibrotic tumors. And as I mentioned before, they tend to be low signal on T1. Although they're bright on T2, notice it's not very bright on T2. It's more similar to spleen. And again, you can see that progressive filling in and that volume loss associated with these peripheral cholangiocarcinomas. How about this patient? What's the most likely diagnosis? I'll give you a few seconds to look at this. See, there's a large caudate lesion. This is T1, this is T2, this is early after contrast, this is delayed images after contrast. Your choices are A, adenoma, B, fibrolamellar, C, focal nodular hyperplasia, D, hemangioma, and E, metastases. And that's C, focal nodular hyperplasia. So why is that? Well, you've got a lesion, and you can see the lesion has a central scar. It's dark on T1, bright on T2, initially doesn't fill in, but shows progressive filling in. And that's classic for FNH. The other feature that you see is you could see that the lesion is fairly isointense on T1, fairly similar to liver, although a lot of times slightly increased signal on T2, but most important, it has homogeneous arterial enhancement, which fades or de-enhances over time. These are the second most common benign hepatic tumor, more commonly seen in the third and fourth decade of life, more commonly seen in females. These are important not because of their symptoms, because they tend to be asymptomatic and not lead to bleeding or malignancy, but you don't want to confuse it with something else. And again, it's useful to look at the pathology, because in this particular case, you can see the presence of a central scar as classic for focal nodular hyperplasia. But as I'll mention, the central scar is also seen in other conditions. So again, similarly on CT, tends to be hypodense or isodense with the liver, as illustrated here, where it's isodense, but again, it has that central scar, as you like to see. And importantly, on the arterial phase, it has homogeneous hypervascular enhancement early on, and then it becomes less intense over time, or less hyperdense over time. Unlike MR on CT, you don't always see the central scar, and often you don't see the central scar enhancing, and it may be harder to see the scar than it is on MR. So these are referred to as stealth lesions because on all imaging modalities they can look similar to the liver, but in my experience, as I mentioned, a lot of times they're a little bit different. But importantly, features are that on the arterial phase, you see that dense, homogeneous, diffuse enhancement, and it fades on later phases. You look for the central scar, not always, but classically described as low signal intensity on T1, high signal intensity on T2, and showing delayed enhancement. And if it's classic, you don't need to do further workup. So here's an example. The question is this FNH. You see a large lesion. You see the lesion is bright on T2, but unlike FNH, what do we see? We see that peripheral globular enhancement with progressive filling in, and in this case, the central scar doesn't enhance. And similar to the prior index case that I had shown you, what is this? This is a hemangioma. What about this patient? Is this FNH? Has a similar bright T2 scar. Lesion is similar to the liver, slightly hypointense on T1. But what's the difference in this particular case? Well, early after GAD, we don't see that homogeneous arterial enhancement, which fades. Instead, we see this heterogeneous enhancement. We see multiple lesions. And what was this? This was metastatic disease, in this case from colon cancer, and clearly not FNHs, sorry. How about this patient? So this is a more unusual case. This is a 34-year-old female who had abdominal pain, had a large lesion, had an area of calcification. Following contrast, it enhanced, but it enhanced slightly heterogeneously, but nicely shows the central scar. MR in this particular case, you could see that central scar. It's dark on T1. It shows enhancement, and it's bright on T2. So if you're taking the boards, you would say that this is FNH. But this one's a little atypical. What's atypical about it? It doesn't have that homogeneous hypervascular enhancement, although I don't have a great arterial phase. It certainly has some heterogeneous enhancement. This is an older case, but we did a sulfur colloid scan, and notice it doesn't take up the sulfur colloid agent. And some FNHs don't, but given all these findings, we were concerned it may be more significant, and this proved to be fibrolamellar hepatocellular carcinoma. So fibrolamellar hepatocellular carcinoma is an uncommon variant of hepatocellular carcinoma, can mimic FNH. It's in the same population as FNH, typically young and middle-aged females without cirrhosis, and the AFP is generally not elevated. They say that the prognosis is better than HCC. It's less invasive, more likely resectable, but still it has a bad prognosis, and it's very rare. So the point being that even where I am, we're a liver transplant center, and we see a lot of referral cases. Most of these are referred from the outside, so it's not routinely that I would suggest fibrolamellar HCC. In contrast, FNH is very common, and if I don't diagnose on a daily basis on MR, or at least on a weekly basis, and I'm making up the number, but it's probably 1,000 times more common to see FNH than fibrolamellar. Generally, the fibrolamellars tend to be larger than FNH, but there's too much overlap to use that as a criteria. Again, the classic board teaching is that central scar is typically hypointense on T2, but as I showed you in the one example I showed, it's not always the case. But in my opinion, the best clue is that you have a heterogeneous lesion and heterogeneous enhancement. In contrast, FNH is more homogeneous and hypervascular on the arterial phase. And the point being, if you have an FNH that has very atypical features, you should at least consider close follow-up, potentially giving gadoxetate or Eovist, or biopsy to exclude fibrolamellar HCC. So here's a 35-year-old female, has this incidental lesion on ultrasound. Again, it's complex. Well, it's echogenic. It's not definitive for hemangioma. Certainly doesn't look like FNH. And you probably guessed it because I haven't shown it yet. But this is a 35-year-old female. The MR, again, I think is better than the CT in this particular case. And in a lot of cases, to look at liver lesions, we could see it's in phase. It's even hard to see the lesion. But notice on the opposed phase, it drops in signal. So again, fat is our friend. That shows us that there's fat. Following contrast, it certainly doesn't have the typical appearance of a hemangioma. It doesn't have that peripheral nodular enhancement, and it's certainly not bright on T2. So given the presence of fat, that limits our differential, and the demographics in a lot of cases aren't helpful, but in this case it was especially helpful in a 35-year-old female. The loss of signal from fat, what do we think? Our choices are A, adenoma, B, FNH, C, hemangioma, D, hepatocellular carcinoma, and E, metastatic disease. And as you would anticipate, this proved to be an adenoma because, again, lipid, same differential, but now the demographics is a 35-year-old female, so think adenoma over HCC and over angiomyolipoma or lipoma because those have macroscopic fat. So hepatocellular adenomas were rare prior to widespread use of oral contraceptives. It's typically seen in women. It's much less common than hemangiomas or FNH. Other predisposing factors include glycogen storage disease and anabolic steroids in males, so we may start seeing it in baseball players. And generally, surgical resection is recommended when it's greater than 4 to 5 centimeters because of the risk of bleeding and the small risk of malignant degeneration. And these are, they've subtyped these, and the ones with the higher risk of malignancy is the ones that are referred to as beta-catenin mutated subtype. CT and MR for hepatic adenomas can be nonspecific, but you want to look for either, as I'll show you, the presence of hemorrhage or fat. Hemorrhage more commonly seen in the inflammatory subtype, with fat in the in this tongue twister HNF1 alpha mutated subtype. Especially if you see it in a young female, then you have to think of a hepatic adenoma. And as I mentioned, I think MR is more sensitive and specific than CT because lipid is only seen about 7% on CT, while it's seen in about 1/3 to 3/4 on MR. And unlike hemangiomas, it doesn't have, as I mentioned, the high signal intensity on T2, nor the peripheral nodular enhancement. So here's a patient that we're fortunate to have on CT, nicely showing that cotton wool peripheral nodular enhancement of a hemangioma and the more heterogeneous hypodense enhancement in this case, at least for an adenoma, although adenomas can certainly be hypervascular and often are. What about hepatobiliary agents? Well, I think hepatobiliary agents can be quite useful, especially in a problem-solving approach to characterize liver lesions because it has the advantage of a hepatocyte phase and biliary excretion. So when we're using the two agents that we can use are GAD-EOB or gadoxetate, referred to as Eovist or Primavist in Europe, and we get delayed images at 20 minutes. We used to use Gad-Bapta or Multihance, but the problem was you had to get more delayed images, which was 1 to 3 hours delayed images, so that may be harder for patients to do. During the hepatocyte phase, lesions with minimal or no hepatocytes, as illustrated, will not accumulate the Gad-EOB or Gad-Bapta, the Eovist or the Multihance. And the functioning hepatocytes, the FNHs, but unfortunately also some of the well-differentiated hepatocellular carcinomas can accumulate the agent and are bright on more delayed images. In contrast, adenomas classically are dark, unlike FNHs, although occasionally there is some overlap. So here's an example. This is an older case where you could see it's hypervascular on the arterial phase. It fades. It's slightly bright on T2, so the question is this FNH? Is this a hemangioma? Or is this adenoma? So in this particular case, We got delayed images. In this case, nicely illustrates the retention of contrast and the presence of a central scar, which is typically seen in focal nodular hyperplasia. How about this patient? Well, the reason I'm showing this is just because I want to show with the EOVIST, you could see that it's arterial enhancing as you'd expect. It has a central scar. Delayed images, there is retention, but it's also important to recognize that the scar sometimes looks very prominent on these FNHs following the EOVIST, and that's not something to worry about, but something to realize that occurs unlike conventional gadolinium, where it would enhance on delayed images. How about this patient? Well, this is a patient with adenoma, and you could see, similar to the other example that I showed you, it has fat, so you probably wouldn't necessarily need in this particular case the EOVIST, but I thought the EOVIST nicely illustrates that you can see that there's some arterial enhancement, and it's fading on the venous phase, but on the 20-minute delayed phase, the lack of uptake, and that's what you classically want to see in these patients with adenomas. And you can tell it's a delayed phase because you're starting to see biliary excretion, so you want to look for the contrast within the bile duct. Another example, in this case, I thought it was helpful to use that hepatobiliary agent because on the CT it looks fairly nonspecific. You might even question, is there a central scar that's enhancing or not, but certainly not clearly having a central scar. In phase, opposed phase, so unlike the other example, it's not dropping. In this particular case, we did measurements. It didn't drop on the opposed phase, but more importantly, what do we see? On the 20-minute delay, we could see the lack of uptake, and that's classic in this particular case for an adenoma. The patient had the right demographics as well. This is a patient seen in the emergency room. The patient presented with acute abdominal pain, anemia, dropped her hemoglobin to 7. She presented to the ER. So now we see a liver lesion with a lot of blood. Again, the right demographics, so this is going to be an adenoma most likely as expected. So they embolized this and had a great response. Without even doing a biopsy diagnosis, the suspicion would be that it's an adenoma, and that was confirmed. So again, you've got a large lesion. If it bled, things you think of as adenoma, especially if it's a young female, hepatocellular carcinoma, certainly if they have risk factors, metastatic lesions, if they have known metastases, although that could be their initial presentation, or hemorrhage into a cyst. But given her demographics and given the appearance, this as suspected turned out to be an adenoma. And rarely, hemangiomas or FNH do not hemorrhage. In contrast, here's another example. So in this case, it looks identical, although in a different part of the liver, in this case the left lobe, associated blood because of acute bleeding, but the demographics were different. 58-year-old Chinese male, so as opposed to an adenoma, you think hepatocellular carcinoma, which is what this proved to be. How about this patient? Well, this patient I'm showing for a reason. It's a 41-year-old male, abdominal pain and elevated LFTs, heterogeneous lesion on the unenhanced and on the post-contrast images. It was biopsied. The biopsy showed adenoma, but because of its size and because of its heterogeneity, it was resected, and this proved to be a hepatocellular carcinoma developing in an adenoma. And this is the main reason that we're always careful in males that have adenomas, as well as the concern about adenomas because they can degenerate into hepatocellular carcinoma. How about this patient? This is a 35-year-old female with right upper quadrant pain. We see several lesions. So the first lesion, low signal on T1, high signal on T2, peripheral nodular enhancement, progressively fills in. I feel like a magician when I show this case, but you can scream out the answer. It's a hemangioma, right? Same patient, another lesion, in this particular case hypervascular on the arterial phase, fades, but just as important, if not more importantly, we see what? A central scar. Initially it's unenhancing, but on delayed images it does enhance, so we can again scream out F and H. And yet again, another lesion, somewhat heterogeneous, slightly heterogeneous on T2, heterogeneous enhancement as suspected. This was an adenoma, and that was the lesion that had to be resected given its size and may have been the cause of patient's pain. So despite having several lesions, you can't assume all the lesions, especially in middle-aged females, are all going to be the same. As illustrated here, you see hemangioma, FNH, and an adenoma all looking differently, but MR nicely characterizing all three. So in conclusion, CT and MR are highly sensitive for hepatic lesions. The most common liver lesions can be identified and characterized with CT and MR, certainly the hemangiomas and the FNHs that have a central scar and have the typical enhancement characteristics, as well as the adenomas, as I mentioned, if they have the presence of fat or hemorrhage. So if you have a patient with abdominal pain and a lesion that bled or has fat and is a young female, especially on birth control pills, what do you think of? You think of an adenoma. Now, let's say we change the demographics and it's an older male or somebody with hepatitis or risk factors, then you start to think of hepatocellular carcinoma. And when the lesions are not classic, again, we can characterize the majority of the lesions, but when it's not classic, I usually want to do a short-term follow-up exam or consider a biopsy. And hopefully I've illustrated, but I think MR offers greater specificity over CT in characterizing liver lesions. Thank you for your attention.